Go ahead.
All right, so we had a gentleman in clinic recently. He was a readmit into our program, previously seen in 2021. Recently released from jail. He was divorced while he was in jail, lost custody of his kids, has no income. He has been living with his sister since being released from prison. Um, there is some strain in their relationship at home. He reports his sister is very overbearing. Like he has to be giving her attention 24/7, so he'll leave to get away from this, and then she'll kick him out. And his only the only place he can go to when he's kicked out is a dealer's house. So he would frequently relapse when he was doing that. Sister eventually ended up kicking him out completely and would not let him back in. Most of the time, she would let him back in within a couple of days of him being kicked out. Um, so he was only with us for about 2 months in total. About a month into it, his sister kicked him out completely. Once that happened, he started living in the dealer's house full time because he had nowhere else to go. So we had frequent relapses, no matter what we tried. I consistently talked to this gentleman about being in a long-term care, or even completing a detox or a 28-day program, any type of higher level of care, and he was adamantly against that because he spent about 3 years in and out of all types of sober living homes and anything like it. So he was in Center for Hope and Healing at the end of 2021. Was there for around 6 months, and was released. He was living in Morgantown and relapsed. Lived on the street there for a few months after that. He went back to the Center for Hope and Healing, completed another 28 days, and then went to sober living for around 3 months where he relapsed again. He completed another 28 days at the Center for Hope and Healing. After he completed that one, he moved in with some friends in Morgantown, in which he was indicted on a previous charge. He failed a drug test while on bond and went on the run, and then was in jail from January 23 to September 23 when we started seeing him again. So we had increased him to daily visits. Was trying to get him in for therapy. He had no phone, so he had to come in person for therapy. Our therapist was partially telehealth, partially in person. So scheduling this gentleman to be able to come to appointments, and he was about a 10-minute walk away from clinic, so he was walking to clinic anyways, but he would no-show his therapy appointments. So we had him increase the daily check-ins, and that lasted for around 3 weeks, in which he was pretty much using every single day that he was leaving clinic. So levels for drug tests were always increasing, always decreasing. Yeah, so we kept him at daily, to which he just stopped coming. So I'm really just kind of curious if there was anything else that anybody else would give advice on what we could have possibly done to help this gentleman, because I honestly do not know.
Thank you so very much for that case.
And I talk very fast, I'm sorry.
No, you're fine. I can always bring it back up if anybody needs me to. Does anybody have any questions before we go into recommendations?
I guess I'm wondering if there's a period during this kind of recovery and relapse phases that he felt like he had good quality of life. When were things going well for him, and what was that like?
So his problem when he was in sober living would be as soon as he got a job and was incorporated back into society, that he would find people that he should not find, which he would start hanging out with the wrong group again, which of course will lead to relapse for him. And that happened all 3 times that he was in sober living. So quality of life wise, I don't know that I could give you an actual answer on what his response would be.
But his recovery environment is really an issue for him.
Yeah.
Any recommendations then going into it further?
I like the saying, same plan, same result. So, he needs a new plan. This is not working for him. So he needs to get together with somebody and say, okay, what could I do differently that my life might go better? This pattern that I'm living in is not working for me. And, maybe try to create a new plan to live differently.
Did he recognize, Hunter, that there was no way he was going to maintain his sobriety living with somebody who's selling drugs?
Absolutely. It was a very frequent conversation.
Did
So the
he?
struggle
Yeah,
Go ahead,
and no, you're fine. Did he, I mean, were there any places else he could look into?
So we tried Jobs and Hope, we tried Telemon. So the issue with Telemon is I think you have to have, what is it, like 2 years of documented homelessness before you're accepted or something along the lines, 6 months maybe, somewhere in between there, which is a big gap. And then we tried Jobs and Hope. My big thing for him was getting him back in with his sister because this was the most stable thing for him. They held him accountable for his drug use and was oftentimes the reason he was kicked out because he would come home at like 2 a.m. They would
Yeah.
question him. Of course, he would admit to using, so she would kick him out. So his big thing was because he's completed so many programs, he thought all that he needed to do was find a job, which would allow him to pay for stable housing. He had a job interview lined up through a friend through a railroad company, quote unquote. When he called the railroad company, they told him that they had never received his application, which started the complete downfall of getting kicked out and moving in with the dealer.
I was just kind of wondering, maybe kind of going back and assessing his motivation, like how motivated is he for change? Because it kind of sounds like, you guys are doing the right thing. You guys might want it more than him, which we run into a lot, unfortunately.
That speaks to the harm reduction model versus recovery kind of, what's a continuum where, we're saving lives, but sometimes we can build good lives too. So he's at the very bottom of this kind of trying to stay alive, right?
Well, and it was a struggle for us too, because I mean, we had no issue continuing to see him daily, but I mean, of course, we weren't going to increase him past daily just because of the continued use. I mean, he was consistently using fentanyl and meth. Um, and then he stopped coming and I tried to maintain contact, but without a phone, I mean, it's virtually impossible.
Did you guys kick around doing any LAIs like a Brixadi or Sublocade on him so you can?
So we had talked about it when he first was mentioning this job because he was going to be away for 10 days
Mhm.
at a time and giving a 10-day prescription, but it didn't go anywhere now.
I mean, that might be something to consider if they pop back up and he wants some kind of treatment. And Daly's asking a lot of anybody, especially if
is.
he were to get a job. It's a little tricky with the continued fentanyl stuff. I wonder how much effect he was getting at all. If he was still taking the Suboxone, like he was testing positive for bup, right? So
As far as, oh yeah, he was still testing positive for BPS.
okay, so he was taking them both together. All right.
Well, and the thing is, I don't know that the fentanyl was not in the meth.
Sure.
So
What were they being sent out for levels or anything? Or
yeah, periodically.
okay. That's sometimes interesting to kind of look and see percentages of stuff.
Another thing I might try with an individual like this is ask him who he admires. A lot of times people meet individuals who are inspiring to them. And then, what can you model after that person you admire that might improve your life? Instead of just kind of going through this pattern of what you're doing that's not working.
Yeah.
He needs to be inspired somehow to change, huh?
Thank you. Dr. Husted, you unmuted. You have more to add?
I never unmuted. I never remuted. So
Oh my
I'm
gosh.
just looking at mine.
Naughty.
I will now though.
Yeah, you will. No, I'm just kidding.
Actually, I have a fentanyl level. Do you want me to? I'm curious if you would think that it was use from meth or. So I mean, it varies from 0 nanograms per milliliter up to 167 in his last 6 send outs. So I mean, I would probably say the 167 is actual fentanyl use, but I mean, there's a 60, a 21, and then a couple low ones.
And those are all pretty low, actually. Usually people are fairly high with regular use of fentanyl because it's so fat soluble. kind of lingers around when you're chronically using it.
Okay.
Did they have norfentanyl levels too, or?
He did, yes. His norfentanyl on the 167 was 389. But then he has a positive fentanyl for 60, but a positive norfentanyl for 616. I mean, his meth levels are, the lowest I have is a 8,000, and the highest is 663 or 63,000.
I mean, he's definitely using meth consistently, but that is pretty consistent with like low dose exposures of fentanyl as opposed to, high intentional use. So.
Okay.
Another thing that comes to mind about this guy is psychiatric issues. He's estranged from his family, his children. Is that right?
Yes.
So I
No
wonder if
contact.
maybe he's kind of escaping from the emotions related to that. Feels like he's a failure in his marriage, and maybe feeling terrible about being separated from his children. And so I don't know. I know he had a therapist, and maybe they were working on some of that. But I wonder if there was maybe severe enough psychopathology that he'd warrant psychiatric treatment.
I don't disagree.
Were there any other meds tried for like methamphetamine use, like Topamax or Remeron or anything like that?
We did not.
And that would be the only other thing you could think of. So if he comes back and he acknowledges the amphetamines are really difficult for him, the cravings, sleep isn't great. Here's some Remeron. Let's talk about maybe switching over to the shot and a little less frequent visits.
Thanks.
Yep.
Great, thank you. Do you have any other questions, Hunter?
No, ma'am. Thank you, guys.
Thank you, and thank you so much again for the case. All right. I'm going to hand it off to Dr. Herschel. You can do a quick intro, and I'll get your slides right up.
All right. Thank you, Elizabeth. So I'm going to talk about buprenorphine for pain in patients with substance use disorders. And for those of you who don't know me, I'm an addiction psychiatrist, and I'm also the program director for the Addiction Psychiatry Fellowship here at WVU. And I wear different hats, and one of the hats I wear here at WVU is working in the Center for Integrative Pain Management, treating people who have comorbid pain and addiction or pain and psychiatric disorders. So this is kind of part of the work that I do here at WVU. So and it's really an integral part of treating patients with addiction. So I thought it would be good to talk about this. Next slide. So here's the Center for Integrative Pain Management at WVU. It's a two-story building. We have kind of a lot of services here. There's a multimodal approach to pain. So that's kind of the leading edge about how to treat pain, chronic pain conditions, is with a whole armamentarium of approaches. So not just pharmacologic approaches, but chiropractic and massage and movement therapy and physical therapy and psychotherapy and psychiatric care. And then they do procedures like pain pumps and stimulators and trigger point injections. And so there's a lot of different things that are being done to help patients with their pain. Next slide. So it's hard to be funny or crack humor about pain, but I do like this. So some people like no pain, no gain. Others like no pain, no pain. So we're going to kind of talk about whether no pain is maybe a realistic expectation for people who have chronic pain. So here's the core concepts about what I'm going to talk about. I'm going to go over some definitions. Then I'm going to talk about pain and opioid use disorder facts. I'm going to discuss some thorny issues related to pain and addiction. I'm going to talk about the multimodal integrative pain management approach, which is really the direction of scientific consensus now about how to treat chronic pain and addiction. And then I'm going to talk about use of buprenorphine for pain in high-risk patients. And then I'm going to talk about the self-management of pain. We don't think about people helping themselves with pain, but that's actually a very important available opportunity for people who have pain to learn ways to manage it themselves. All right, next slide. All right, so some definitions. Acute pain This is usually straightforward. So what happens is that somebody has an injury or an underlying condition that can be identified and treated, and then the pain goes away as expected quickly after the injury or the illness is resolved. And then chronic pain is something that persists despite the fact that the illness or injury is healed or in situations where there's no known cure for the disease. And so some people say chronic pain is after 3 months of pain. And some people will even extend that to 6 months of pain. And so we're talking about over a long period having ongoing pain. That's when you're talking chronic pain. And then there's different kinds of pain. So we have somatic pain, visceral pain, and neuropathic pain. And somatic pain is pain related to the tissue of the body. And so it's well localized, attributable to structures, and the quality of it is stabbing, aching, and throbbing. Whereas visceral pain is like the guts, your internal organs and your viscera inside your body, and that's poorly localized, dull, and crampy. So it's a different kind of pain. And then a third kind of pain is called neuropathic pain, and this is dysfunction of the nervous system. So it follows the pattern of the dermatomes or the nerves, the pathways of the nerves, and it's lancinating, it's sharp and shooting and burning along these nerve pathways. And so these three types of pain can actually be treated differently. And you're going to see that Suboxone has a different efficacy for different kinds of pain. And then a last kind of pain that I want to talk about is total pain. And a hospice nurse who's famous named Cicely Saunders says that total pain is the suffering that comprises all of a person's physical, psychological, social, emotional, spiritual, and practical struggles. And so when we think of addictions and people getting caught up with opioids or other medications to deal with pain, often what they're addressing is total pain. So not just physical pain or emotional pain, but total pain. All right, next slide. And then there's something called high impact chronic pain. And high impact pain is when pain affects other domains of life. So maybe pain interferes with sleep or interferes with activity. So it's impacting the quality of life of the individual. And so high impact chronic pain is super important. Next slide. All right, so let's talk about some facts related to pain and opioid use disorder. So 50 to 70% of patients with opioid use disorder have chronic pain. So very high percentage. And of course, we know with the opioid epidemic that a lot of people got into this epidemic because they were having their pain treated by somebody, and then that clinic closed or that provider was no longer prescribing, and they got cut off from their prescription opioids and then turned to heroin or eventually fentanyl, and so or other kinds of opioids off the street. And so that's kind of how we got into this epidemic. And then 64% of patients with opioid use disorder report using opioids to address pain. So I don't know if you're aware of your patients, how many of your patients that you treat with Suboxone or other forms of buprenorphine for opioid use disorder actually have pain as well, and you haven't really kind of explored that. So please, look into that with your patients and see, if their needs are being met as well as they can for their pain conditions. And then another thing that's important is that patients with opioid use disorder have a lower pain tolerance by the cold pressor test. And what the cold pressor test is that there's a bucket of ice water, and the person puts their arm into the bucket of ice water, and it gets unbearable when they pull their arm out because it's so cold and painful. And so you can compare the analgesic effect of different kinds of opioids by how long the person can leave their hand in the bucket of water. And so patients with opioid use disorder cannot keep their hand in the bucket of ice water very long. All right, next slide. So what about some thorny issues? Well, untreated pain can jeopardize recovery. So, right, the person is going to try to ameliorate their pain or palliate their pain themselves. And then opioid status post-surgery can trigger an addiction relapse. And so if somebody has surgery and they're given hydrocodone or Percocet, and they start to trigger that use behavior again, they may go off to the races with an opioid use disorder. So it works both ways. Untreated pain is a problem, but treating pain with opioids can also trigger problems. And then some patients may malinger or exaggerate pain to obtain more medication. So I think we're all aware of that. And so you have to, what you do to differentiate is to look at functioning. Is this person laying in bed all day? Someone laying in bed all day who's got pain is not doing well. Whereas I had a patient in the high-risk pain clinic who was on Suboxone for pain. And he said, oh yeah, this medication doesn't help my pain at all. I've got terrible back pain. And then we're talking later in the conversation, he says, oh yeah, but I got a deer this weekend and I dragged the deer for 2 miles to my truck and put the deer up on the back of the truck. And I'm like, that's pretty good for somebody with back pain, So you really want to look at their functioning. That's what matters more than just if they say if their pain is being relieved adequately. And then, of course, diversion, abuse, and trafficking of opioids is important. And then there's something called pseudo addiction. Does anybody know what pseudo addiction is? So pseudo addiction is when somebody seeks more medication to relieve their pain. So it's not really an addiction, but it looks like addiction because I need more, I need more, I need more. But actually, it's their symptoms are not being addressed adequately by the treatment, and so it looks like addiction. And then there's something called opioid-induced hyperalgesia. Does anybody know what that is for 100 points? No, okay. So what happens when you expose somebody to opioids over a long period of time is that the brain kind of adjusts to the pain threshold, and they become more and more sensitive to pain over time. It's kind of this central sensitization that happens in the brain. And so eventually they look like somebody with fibromyalgia, where if you just touch their skin, it's painful. And so they get that hyperalgesia, even though they're being treated with opioids. And so what you do in that situation is actually lower the dose of the opioid to relieve the hyperalgesia. So sometimes treatment of pain can actually cause pain. And then there's something called withdrawal hyperalgesia. And so you can imagine if somebody's in withdrawal, that's going to make the pain sensitivity go up a lot. And so you can get hyperalgesia from low amounts of opioids and withdrawal, and you can also get it from long periods of elevated amounts of opioids. And I also wanted to mention online clinician reviews. So if you're treating pain and addiction in a patient, and they really want hydrocodone, and you want to give them buprenorphine or some other treatment of pain, and they're really dead set on getting their drug of choice, they may write a terrible review of you in the on the internet on health. I'm trying to think what the health grades, I think, is one of them. And so there's different organizations that rate physicians or other clinicians. And so you may find that you have kind of terrible reviews by patients because you're really doing the right thing for them. And so maybe the goal is not actually to satisfy this addictive disordered patient, but maybe do the right thing for them to help them function well and live the best quality of life that they can. I hope that makes sense. So don't be disheartened if you get negative reviews. And if you're a good clinician in chronic pain, you're going to get some negative reviews from people who aren't really interested in their well-being. They're more interested in, getting high with something that can be abused. Next slide. So what is integrative pain management? So this is the approach that is the really gold standard of care for chronic pain now. And so what you want to do is use a multimodal approach, make a pain diagnosis. What is the etiology? What's the cause of this person's pain? and what are the tools that we can use to address this. And so there may be pharmacologic and non-pharmacologic things that can be done, procedures. I mentioned some of the procedures, so pain pumps and stimulators and injections and blocks, and there's lots of procedures that can be done, and chiropractic and massage and movement therapy. So it may not just be that a pharmacologic agent is the answer for this individual. And so you've got hot and cold packs and massage and physical therapy and movement therapy and biofeedback and acupuncture and electrical stimulation, chiropractic. Meditation can be helpful. I don't know if you guys are familiar with mindfulness meditation. That can be good for addiction. It's also great to not kind of be engulfed in your pain experience, but step back and be a witness to your pain experience. And you get that detachment that makes pain less troublesome. And music therapy can be helpful, and exercise and CBT, looking at pain catastrophizing and pacing of activity. Hypnosis can be helpful. Relaxation techniques and deep breathing, breathing exercises can be helpful. Guided imagery, cognitive distraction, psychiatric care, and nutrition. Even eating anti-inflammatory diet with the Mediterranean diet can be helpful for pain. And so there's lots of things that we can do for these patients. So if you're stuck with somebody and their pain's not being adequately addressed, maybe you should be thinking of more of an integrative pain management approach than just trying to treat something pharmacologically. Next slide. All right, so this is a little bit tough to see, but going back to that cold pressor test, how do they compare the potency of, say, morphine to buprenorphine? And so with the cold pressor test, 30 milligrams of oral morphine, the top of this chart, is equivalent to, if you look at buprenorphine, which is third from the bottom, and oral is the second column. So 0.3 milligrams of buprenorphine is equivalent to 30 milligrams of morphine. So it's like 100 times more potent than morphine. Now, Mark Garofoli would said, I think they think 30 times more potent here at WVU, but it's somewhere in that range from 30 to 100 times more potent for analgesia. And then if you look at the last column, the duration of effect, so buprenorphine lasts 4 to 6 hours for analgesia. I see as much as 8 hours maybe with sublingual buprenorphine. So the analgesic effect is not as long as, like, when we're treating addiction, we might have patients take all their medication at once. But if for pain, you really want to divide it up through the day. Next slide. All right, so what should we do with patients who have pain and a history of addiction with other than opioids? So say someone's an alcoholic, and are you going to want to give an alcoholic who has chronic pain hydrocodone? Probably not, because they're likely to go off to the races with an opioid use disorder because they've kind of already have that addictive kind of physiology in their brain reward pathway. And so you worry that something habit forming is going to be a problem for them. And so these are what we call high risk patients. So not only people who've had opioid use disorder or misuse of opioids, but really any substance that's been out of control is going to put a person at risk. If opioids are the right thing for them, you're probably not going to want to prescribe, a mainstream opioid. You're probably thinking buprenorphine would be safer for them. And so we have an urgent need for new policy about Suboxone. Should we be able to use Suboxone for somebody who's an alcoholic and has chronic pain and really needs an opioid for their pain diagnosis? Shouldn't we be able to use Suboxone for that? All right, so some keys to using buprenorphine for pain in high-risk patients. So for those who are naive to opioids, you really just want to start at like 1 milligram twice a day of buprenorphine. So just a tiny little dose, because it's potent, 30 to 100 times more potent than morphine. So it's the people who are more accustomed to opioids where you're going to be using higher doses. And then we talked about the duration After surgery, if you're using buprenorphine for analgesia, we're talking more like 4 to 6 hours status post-surgery. And then we all know about the ceiling effect of buprenorphine. So buprenorphine is safe in overdose, much more so than, say, methadone or another opioid. And that's because it's a partial agonist. But there's been a lot of debate about, does this play a role in analgesia or pain relief? Does it matter that it has this kind of partial agonist effect? And what they found is that you can actually get to pretty high doses and still have some analgesia, even though you're kind of saturated in the mu opioid receptor system. So the ceiling effect doesn't seem to play a role in analgesia as much. And then you guys know about constipation. So very common side effect with patients being treated with buprenorphine for pain as well as addiction. And we use senna oil, which stimulates the bowel. Fluids and prune juice and stool softeners are kind of getting the things going from above. Senecot S has both a stool softener and stimulates the bowel. And then there's these newer drugs called peripherally selective mu opioid antagonists. And so what they're doing is blocking the opiate receptor in the gut. So it's not absorbed, it's just in the gut. And that puts the gut kind of into withdrawal so the person can go to the bathroom. And so Movantik, I don't know if you guys have heard of Movantik. That's an example of a peripherally selective mu opioid antagonist that helps with constipation. And then I know you heard me say activity is so important. So when you're measuring the relief of pain, you're much better off asking the patient, how's your functioning? How's your quality of life? Are you laying in bed all day, or are you getting around doing things? Are you functioning? Can you play with the kids? Can you do activities that you would normally do in your day? Or is it limited? How active are you? And so I don't tell patients that's what matters to me, because some patients may want to game the system and, I have no activity, I can't do anything, I need more and more medicine. So it's almost like you have to kind of be a little bit insidious about how you're asking about their functioning so that you can get to this and determine if their relief of pain is really working. And so you want to engage a multidisciplinary, multimodal care and not trigger this addiction system in your treatment of these patients who are high-risk patients. And then use analgesic adjuvants. So you might use SNRIs or tricyclics or gabapentinoids, and then low to moderate dose Suboxone is sensible for high-risk chronic pain long-term. So I have some patients who've been on, reasonable doses of Suboxone for their chronic pain, for 5 or 6 years and done well. And then one of the getting back to the policy issue, so technically you need a diagnosis of opioid use disorder for insurance to cover the Suboxone. But the pharmacies do not ask you what the diagnosis is. If you don't put a diagnosis or a reason for the medication on your script, they'll still fill it. And so, but technically you need a diagnosis of opioid use disorder for insurance to cover. Next slide. All right, so let's talk about the potency of analgesia for buprenorphine with these different types of pain. So somatic pain, where it's the tissue of the body is being affected, like your bones and your muscles and your joints and those sort of things. Suboxone, buprenorphine is great. Visceral pain, where you have like I'm blanking on what they're called now. Where your viscera, your internal organs, and your digestive tract are causing you pain. That it works well for that. With neuropathic pain, Suboxone and buprenorphine are only moderately effective. And so often you'll have continual neuropathic pain if somebody has diabetic neuropathy or they have an injury to a nerve. You're often going to need to use other agents to help with the neuropathic pain, like gabapentinoids or SNRIs like Cymbalta or Pristiq or Effexor, or tricyclics like Elavil or Mipramine or Doxepin. So sometimes you have to use these other medicines. And then for total pain and high impact pain, you really want to focus on advancing quality of life. And so when I work with patients in the high-risk pain clinic, I say, our goal is to give you the best quality of life that we can. Let's focus on how we can really develop and build up a good quality of life. See where the limits are and what you're doing and how we can improve things and make life more meaningful and enjoyable for you. Next slide. All right, so what about the buprenorphine long-acting injectables for pain? So both Brixadi and Sublocade, the pharmaceutical companies have expressed no interest in studying pain with these formulations, and they are not approved for pain. But interestingly enough, the multi-center CTN trial, which is looking at Brixadi, I know Dr. Husted is involved in that CTN study, and lots of providers at WVU are involved in this multi-center trial. They are collecting data about pain. It just hasn't been analyzed yet. I spoke to Roger Weiss, who's the kind of the principal investigator of the CTN study, and he said that they'll open up the data and take a look at this eventually, but it just hasn't been done yet. And then when you think about these sublingual formulations of buprenorphine versus long-acting injectables, the issue is interesting. So why is it that sublingual given 3 times a day works better than once a day? Is it like the peak and trough kind of effect? So you absorb the medicine and then it wears off, and you absorb the medicine and it wears off. So is it like a peak and trough effect? And so with these long-acting injectables, the peak and trough is over a whole month. So you're really at a point where there's like a therapeutic blood level over a long period. And so the question is, will that provide the analgesia that these peak and troughs do with the sublingual? Next slide. All right, so I know this isn't really using buprenorphine, but when you're treating people for pain, you definitely want to empower the patient and help them realize that, hey, there are things that you can do in your own life to help manage pain. And it's very nice for patients to feel like they can have some impact on what they're experiencing and that they're not helpless, victims of their pain, just gonna be passive recipients of healthcare. That they can take on an active role and manage pain to some degree themselves. And so I've got 14 items here of things that patients can do. And so the first one is something called expectation management, which involves realistic goal setting. And so you have to kind of avoid tendencies toward unrealistic expectations. And that's both expectations about the total relief of pain and expectations about what their functioning is going to be. So you got to kind of be sensible and say, I'm looking for better quality of life, not a miracle necessarily. And then also differentiating good pain from bad pain. So good pain is pain like fitness related pain where you're building up your strength and it's good for your body and your mentality. So that's good pain, whereas bad pain is destruction to the tissue. And so if you can find a silver lining in your pain, that's going to help you feel to kind of change your mindset about the pain experience you're having. And then lifestyle optimization is good for pain. So we talked about diet, the anti-inflammatory diet, and movement is helpful. So people think, if I have pain, I'm going to wait until the pain goes away before I do anything. I'm just going to sit around and wait till the pain goes away. But actually, it's better to move. It's better to have some movement, but pace yourself, not overdo it, but have some movement, and that will help in the relief of pain. So I had a patient in the high-risk pain clinic at the Center for Integrated Pain Management, and she got a job in housekeeping at a hotel. And she thought, there's no way I'm going to be able to do this job, but I'm going to try it. And then a couple weeks later, she came back and said, I feel better than I felt in 10 years. I'm active now. I feel way better. I have some pain, but I function way better. And so movement is helpful. And then restorative sleep is helpful and a mindset. So, having a taste for challenge and a stubborn hope and conditional optimism. So optimism based on effort, not just passive, like complacent optimism where you expect things to happen for no reason. And so, developing a good mindset can be helpful. And then eliminate lifestyle abuse. So if you're not taking care of yourself, that's not going to go well for pain. And then the fourth thing is challenge catastrophic thinking. So if you're thinking, oh, this is something terrible is going to happen, the harm alarm goes off, you're experiencing pain, and this alarm goes off in your mind, something terrible is happening. So you have to challenge that and think, now, has this already healed? Maybe I have some pain still, but I think this part of my body is healed. And so there's nothing really to worry about. I just have to manage this discomfort. Next slide. And then we talked about pacing activity. So it's good to have some movement, but you don't want to overdo it. So you kind of want to find the right amount of activity for the individual, for yourself, where pain is not exacerbated by movement, but that you're having some functioning. And then mental toughness. So we get these stoic folks who can tolerate lots of pain. And so mental toughness can help in dealing with pain. And stress recovery can help also. So unwinding routines and people say stress recovery is the new fitness. So what do you do to relieve stress? And then I know Laura put some things in the chat about mindfulness meditation. So meditation is definitely something patients can do to help manage pain. Next slide.
Yeah, there's actually specifically an evidence-based treatment called mindfulness-oriented recovery enhancement, specifically for the treatment. It's a mindfulness-based intervention for those who have both opioid use disorder and chronic pain.
Yeah. And if you're interested in learning how to do mindfulness meditation, there's a famous gentleman named John Kabat-Zinn from Mass General Hospital who has the Harvard Stress Reduction Clinic. And he uses mindfulness, and there's lots of YouTube videos by him. He's a really fascinating guy. All right, so number 9 is yoga. So yoga can be helpful. I have a patient who has ankylosing spondylitis, which is like a fusion of the joints that develops and is painful. And so he does yoga to stretch his joints, and that kind of activity. It's spiritual as well as kind of relaxing and physical, and so that can counteract pain. And there's evidence supporting that. And relaxation techniques. So you've got systematic progressive muscle relaxation and 4-4-8 breathing. I like is a breath therapy that can help relax the body and the mind. So both of those are helpful for relieving pain. And then self-hypnosis. So people think someone else is going to hypnotize me and I'm not going to experience pain. But actually what you really want is to learn how to hypnotize yourself. How can I dissociate away from the pain and kind of let go of it, like I'm watching a movie and I'm absorbed in the movie and not noticing anything else. And so self-hypnosis is a great way to manage pain. And there's a famous hypnotist named Milton Erickson who had polio, and he used hypnosis to treat himself and then became probably the best hypnotherapist this country has ever had. He's dead now, but there's something called the Erickson Foundation, which is around the world and centered in Phoenix, Arizona. It's a great hypnosis center. Next slide. And then number 12 is distress tolerance. So we think of this with the dialectical behavior therapy, but how much can you tolerate distress? And so there's techniques that you can use. Mindfulness is one of them, but also softening into the pain experience rather than resisting it can help with dealing with pain. And looking at this as this too shall pass. So pain comes in waves typically, and if you can ride the kind of surf the wave like you would a craving, that can help. And then detachment can help. We're talking about that with mindfulness and also with hypnotherapy. So if you can detach away from the experience, then you become less troubled by it. And being inoculated by stress, so kind of saying, hey, stress makes me tougher. And so when you have negative experiences, kind of being able to welcome them because you realize that makes you a more resilient person. And then we already talked about differentiating good pain from bad pain. Next slide. And then healthy activities and hobbies and employment and education. These fend off idle time and boredom that exacerbate pain. And so when patients say they're bored, I say, you know, hey, goals are the antidote to boredom. People think entertainment is the antidote to boredom, but actually, I think goals are the antidote to boredom. You know, if you have goals in your life, life becomes interesting. You have things to pursue and strategies to develop and, you know, resources to look into to help you reach your goals. And so life becomes much more interesting for patients if they have goals and activities and hobbies and things to occupy their time. And then the last thing is acceptance. So I don't know if you're familiar with acceptance and commitment therapy, but that can be helpful for chronic pain. And Lisa Paul, who used to be a therapist here at WVU, she used to say, you know, just the way someone can fall in love, you can fall into acceptance. And so you experience yourself less defensively. And so what happens is people, you know, if you kind of fight the pain, I'm going to resist it and fight it. It intensifies in this battle. And so it's almost better to welcome it and accept it, and then the pain melts away. It's counterintuitive, and people don't realize that can be helpful. But when you get good at that, you can really ease into the pain experience, and it's much less troublesome if you can have kind of an accepting attitude about that. Laura, do you know much about acceptance and commitment therapy?
Not specifically as applied to the treatment of pain, but it certainly makes sense that it would be applicable.
Okay, thanks. All right, next slide. All right, so why does self-management of pain work in the treatment of pain? And basically, this boils down to something called neuroplasticity. And so what neuroplasticity says is the brain gets good at what it practices. And so if the brain is practicing pain, it gets good at pain. If the brain is getting good at practicing, you know, addiction, it gets good at that. But if the brain is practicing self-management of pain with acceptance and mindfulness and you know, working on a healthy lifestyle and all these positive things to do with your mind, the brain, there's only so much cortical real estate in the brain. And so it can't be doing everything. So what you focus on, what you're doing with the brain is what the brain gets good at. And that kind of takes over, it occupies the activity of the brain. And so what you want to think about is what should I be doing with my brain that's going to be useful for me and helpful and productive and positive rather than letting pathology overwhelm my brain. Does that make sense? I hope so. Okay, next slide. So utilizing the fundamental science of chronic pain self-management means not just putting out the fires of chronic pain, but actually to be able to ably govern fire itself. And so what happens is you're getting kind of control of this process, the process that maintains the pain and redirecting it to something more positive. All right, next slide is my references. So any questions about Suboxone and pain management or other aspects of pain management of these high-risk patients? We just have a couple minutes, I guess, until the focus group, huh?
No worries. Yeah, but I still, you know, we still have time if anybody has questions or comments. And thank you again so much, Dr. Hirschler.
Have you
Yeah.
tried using Butrans for pain? Because that is approved for pain.
So there is Butrans, there's also the buccal, the cheek formulation, Bunavail, that can help with pain. The doses are much lower than they are with Suboxone or Zubsolv or the long-acting injectables. And so for people who have been using opioids, they're not going to get much relief from these tiny little doses.
Well, for those that you're talking about, like the person with alcohol problems that would use an alternative. I'm just kind of thinking out loud that that might be a better formulation for them.
It could be, yeah.
Thank you. And there was a chat saying they use topicals.
Yes, you've got capsaicin and yeah, so some of these ointments that can be helpful are another way to treat pain. Yes, that's correct.
Thank you. Anyone else?
I was going to point out, sorry if anybody's done it. Has anybody else tried to order Movantik for opioid-induced constipation? It will get paid for now through Medicaid. So has anybody else tried using that if your patient has
Yeah,
constipation?
Jeremy, I use it some, and
Yeah.
I've been able to get it approved.
Yeah, for a while it was blocked though, that it was strictly, they said if it was opioid induced constipation from MAOUD, it was blocked, but now it shouldn't be too hard if anybody needs to go that direction.
Thank you for that. Thank you. Magnesium, is that the citrate kind, I think, for constipation, or if it creates
Yeah,
too
so mag citrate is like a really big gun for constipation. I think if you use that too much, you get some electrolyte abnormalities, but it does work, yeah.
naltrexone.
Yeah, so that's what they use. If there's a naltrexone that's not absorbed, so I'm blanking on what it's methyl naltrexone, I think it is. That's one of the peripheral selective mu opioid antagonists.
Thank you, guys. Thank you for the chats and thank you for discussion. Anything else before we move forward? All right. Well, thank you again, Dr. Hirschler, as always. Really appreciate it.
No, you're welcome. I hope that's helpful for you guys.